Now let's talk about traumatic brain injuries, or TBIs, in pediatrics. A TBI is any head injury that involves the scalp, skull, meninges, or brain that is a result of a mechanical force. The most common causes are falls, being struck by or striking an object, and motor vehicle injuries. It's important to understand the pathophysiology of TBI in pediatrics. External forces cannot be well absorbed by the skull, and consequently, there are associated acceleration and deceleration injuries that happen when the brain, which has the consistency of not quite set jello, is rocking around inside of the head. In addition, it doesn't help that a child's head is larger in comparison to the rest of their body, and they have less musculoskeletal support, leaving them at a higher risk for worse injury. Primary head injuries are those that occur at the time of trauma, and they can include skull fractures, contusions to the brain, intracranial hematomas, or even diffuse axonal injuries. However, one of the things we need to do in the nursing care of pediatric TBI patients is prevent subsequent complications, such as hypoxic brain injury, when the brain does not get enough oxygen, damage from increased intracranial pressure, and cerebral edema. This is a good example of the forces that you can see exerted on the brain during a direct impact to the frontal lobe. You can see here, C points forward, where the brain hits the front of the skull at letters B and A. Also, under C, you can see the bridging veins, which are fractured here and then can result in intracranial bleeding. Letter D are the acceleration and deceleration injuries. And then letters E's are where the brain hits the bottom of the skull. As we said before, the initial and direct impact to the brain is not the only source of brain injury in TBI. Hypoxia, ischemia, hypoglycemia, or seizures can also cause further brain injury. And if there's enough force or rotational forces, you can get diffuse axonal injury, which affects the actual axons of the neurons that are in your brain. In addition, increased ICP with brain swelling results in pressure necrosis, because it's putting pressure on parts of your brain that are then not perfusing as well. Here you can see a list at the top of primary head injuries, which then have potential complications listed here at the bottom. Additional complications of head trauma include epidural hemorrhage between the skull and dura that is usually arterial and appears quickly, subdural hemorrhage, which is between the dura and arachnoid membrane. This is usually due to impaired integrity of the bridging veins in the brain. Therefore, this is a venous bleed, and this is the one that we need to be on the lookout for hours after the injury. You can also get bleeds within your brain, and like we said earlier, cerebral edema, or even brainstem herniation. Here you can see two examples of brain bleeds. The top, letter A, is an epidural bleed. The bottom, letter B, is a subdural bleed. In both cases, the volume of blood is pushing against the brain, and we will see changes in their neurologic status. Just like with any inflammatory reaction or injury, you're going to have swelling and edema. This usually peaks at 24 to 72 hours after injury. Therefore, we have this golden window of time to help prevent additional complications and secondary brain injury. There's two different mechanisms by which cerebral edema happens: cytotoxic edema and vasogenic edema, which are explained here. Probably the most commonly referred to traumatic brain injury is the concussion, which is any alteration in neurologic or cognitive function with or without loss of consciousness after a head injury. Symptoms can range from mild to moderate to severe. Keep in mind that your head and brain are also just made up of normal tissues, so you can still have contusions, lacerations, and all kinds of other injuries as well. A coup injury is bruising at the point of impact, and contra-coup is bruising at the site removed from the impact, or, as we saw in the previous pictures, acceleration and deceleration. Skull fractures are not uncommon in pediatrics. However, keep in mind, because the skull is not done fusing yet, it is more flexible, so it takes more force to fracture the skull of an infant than it would an adult. Some more sequelae that we won't talk about here of TBIs include post-concussive syndrome, post-traumatic headaches, post-traumatic seizures, and hydrocephalus. Clinical manifestations of TBIs in pediatrics include minor injuries that may or may not be associated with loss of consciousness. The child may be irritable, pale, or may have an episode of vomiting. These patients are typically observed and then discharged home. Signs of progression or worsening TBI can include either worsening somnolence or worsening agitation. They can have focal or lateral neurologic changes, and we can see drastic changes in their vital signs. Some severe clinical manifestations of TBIs include signs of increased intracranial pressure, which we talked about earlier in the video series. In addition, they can have the bulging fontanelle. They can lose movement of half or all of their body. And because your brain is responsible for thermoregulation, you can have an elevated temperature as well. Damage to the cerebrum is a little bit different, and you can see different cerebellar signs, including ataxia, dysmetria, which just means uncoordinated movements, and a moderate elevation in temperature for 1 to 2 days after the injury. The following are some red flags that, when present, need to be addressed immediately in the child with a TBI. Changes in respirations, wide fluctuation or bradycardia, widening pulse pressure, asymmetric pupils, or bleeding from the nose or ears. Keep in mind that the first 3 bullets here are what we talked about earlier, the Cushing's triad. The care of any pediatric neurology patient, but certainly the TBI patient, is complex. We tend to use a multidisciplinary team and very strict protocols when caring for these patients. We begin with a focused neurologic examination, and then we need to perform frequent serial examinations so that we can recognize changes early. No one spends more time with patients than nurses. Therefore, you have a critical role in the detection of signs of worsening TBI or increased intracranial pressure. Our initial assessment of the patient with a TBI includes a detailed history, assessment of their ABCs, evaluation for shock, and, like we said earlier, a focused neurologic examination. Again, you may want to anticipate that the child will likely need some type of imaging, whether a CT scan in emergent situations or a scheduled MRI. Also, the patient will need lab work such as electrolytes, glucose, or even bleeding studies. Not all head injury patients need CT or MRI imaging. In fact, there are specific criteria published that are followed to decide whether or not a child who's had a head injury requires a CAT scan. An example is listed here, the PCARN criteria. The general goals of nursing care of the child with TBI include maintaining adequate ventilation, oxygenation, and circulation. Monitor for and treat any signs of increased intracranial pressure. Minimize cerebral oxygen requirements, and this is what we spoke about earlier, by minimizing stimulation, as well as positioning the patient appropriately. You're also there to support the child and the family during their recovery. The treatment and management of TBI in pediatrics is similar to concussion, based on the degree or severity of illness. With mild TBI in children who have not lost consciousness, they can be observed at home. However, you want to make sure that you give the parents or caregivers a detailed list of signs and symptoms to report. Children with severe injuries, those who have lost consciousness, or those who have an abnormal neurologic exam must be hospitalized and cared for by a multidisciplinary team. Treatment and management of the TBI for the hospitalized child includes assessing the ABCs, C-spine stabilization, strict NPO and careful IV fluid administration. As you can remember from our discussion about intracranial pressure, we don't want to give them too much fluid and cause cerebral edema. In addition, it's likely that this child cannot swallow without aspirating, so they are not allowed to have anything by mouth. You want to do frequent pain assessments, however, we tend to limit our sedating medications because this can have a drastic effect on your neurologic exam. Neurologic exams are frequent and may be ordered up to every 5 to 15 minutes. In the older child without a fontanelle, who has increased intracranial pressure, whether due to a TBI or not, we have options for surgical management. One example you can see here is a craniotomy, where basically a bone flap is taken out of the skull and the skin is then stitched back over the bone flap. This creates, in essence, an artificial fontanelle. However, we can also place a burr hole, a subdural drain, or even an EVD, as you saw earlier in the presentation.